Dr. Ducournau will talk to us about the advantages of the ILM blue.
Yes, thank you. As we want to remove the Muller cell hand feet, as we saw, I think it's easier if we could differentiate them from the posterior haloid. If we use the trip and bloom like Jersey does, Jersey is a fan of the monochromic clay paintings, you know. Everything is blue. Using trip and blue, in fact, is like using infrared glasses in a nightclub. You see very well all the human beings, but you don't know if the person you invited to dance is a male or a female. More seriously, imagine if the police could dye in blue only the terrorist. They will decrease the number of collateral damage. This is why I think it's really useful to differentiate the structures. The blue of Kumasi, the ILM blue, the BBG, as you said, is specifically linked to the arginine, the tyrosine, tryptophan, histidine, phenylalanine, which are cytoplasmic membrane protein located at the level of the ILM. This is to say, located in the Muller cell hand feet and in the astrocyte, exactly what we want to remove. They are not dyeing the ILM. You must remember that. ILM blue doesn't dye the ILM and cannot dye the collagen fibers, the posterior haloid, as they cannot be linked to extracellular protein, and specifically the collagen. So with ILM blue, you will better understand the pathogeny and therefore perform less manipulation. Look at this example. I have already injected the ILM blue. And there is a first thing that you can see immediately is that this is the hyaloid, the plaque of hyaloid. And here you have it is dyed, it is colored, so you have the Muller cell hand feet, which are free of fibers. So if we want, for example, to start the peeling and to do the peeling in one maneuver, you know that we will start here. And removing the Muller cell hand feet, you will remove also, of course, the plaque of hyaloid. But look, that there is a blue staining here at the edge of the plaque of hyaloid, and you can see that the stain in the external surface of this plaque of hyaloid, of the edges. So to demonstrate you that we don't color the ILM, I remove this colored tissue, and then I remove the hyaloid plaque, and then you will see evidently, after injecting a second time ILM blue, and I accelerated the video to shorten it, and we will start again here under the plaque of hyaloid, and you can see that now we are removing the ILM. So this blue staining at the periphery could not be the ILM. It was the astrocytic proliferation that went through the ILM and proliferate on the external surface of the posterior haloid. This is it, okay. This is the animation. So, in fact, the ischemia induced astrocytic proliferation that proliferate on the external surface of the posterior haloid. Also, you will avoid doing mistakes. Look at that case. Here you have the plaque of hyaloid. Here you have the ILM on the Muller cell hand feet free of plaque. And look here, there is a zone without staining. And if you dye everything, if you colored everything, you could start here. And if you start here, you will attack directly the fibers, the nerve fibers. So this is why I like to differentiate the structure. I like to color specifically the Muller cell hand feet and the astrocytic proliferation, as it allows me to better understand. Of course, Jersey is so dexterous that it can work perfectly with trip and blue, but trip and blue is more toxic than blue of Kumasi, as well as ICG is more toxic as trip and blue than trip and blue. Thank you very much.
Thank you. So my question again to the Kumasi blue users, have you observed any complications?
The major complication is that using this dye allows everybody to peel the ILM. So you don't need to be dexterous to do it. So it's a severe complication because we are speaking of a surgery that can be made by anybody.
Excellent. And you're saying that we can repeat the dye if needed, you know?
Yes.
We have to think about it.
It is really important at the end of the surgery to re-inject to see if you have done the job perfectly.
Thank you very much. Dr. Hannah Jajak-Petrus will talk about the macular ILM peeling with lutein-enriched dye in high myopic eyes.
Good morning. As an introduction, I would like to say something what is lutein and zeaxanthin. So there are two main ones of 600 natural plants pigments synthesized by plants, algae, and photosynthetic bacteria. Have no vitamin A activity as they are unable to be converted to retinol. Human body is unable to synthesize lutein and zeaxanthin, and as such their presence in tissue is only of dietary origin. Lutein selectively accumulated in different parts of the human eye. Due to the polyanic chain, donate an electron to reactivate oxygen species which are generated continuously in the retina, mainly by the blue light. Works as an antioxidant and as a blue light filters to protect the eyes from oxidative stress, such sunlight exposure. The rationale for lutein use is an adjunct tool for dyeing intraocular structures is that it is able to quench photochemically induced singlet oxygen. Such activity seems to be of great importance in cases of prolonged light exposure time, for instance in high myopic eyes with vitreoskisis and posterior atrophic changes in choroid. ILM peeling is not easy but crucial in high myopic retinal pathologies, for instance macular whole retinal detachments and macular foveoskisis. I would like to present a film for last two terrific cases. So this is actually the second operation of the retinal detachment in high myopic eye, and you see that it is a mixture of trypan brilliant and lutein, which is so heavy and is capable to dye a different structure. The lutein, as a suspension, can dye the vitreous, but actually it was a second operation. Therefore, you see that the ILM peeled, the ILM is dyed better outside the posterior pole, as it will be illustrated further on, that in the posterior pole there is a choroid atrophy, so the dyeing effect is minimal. And we also, not even the beginner, but also experienced surgeon is terrified not to harm, but to protect the myopic thin retina. Therefore, it is very stressful, yes, just to begin the peeling. and even to try to take the ILM over the hole, which is can be at the border of the staphyloma with the choroid atrophy and the outside better visualize ILM. So you see how difficult can be a condition. The second film is in a case of macular, high myopic macular phovoschisis. And also the dying effect is not enough. So the repetitive dying is mandatory to visualize the pathologic layer lying and provoking the phovoschisis in myopic eye. So lately, due to, according to the literature, in 2014, the different mixture combining lutein and zeaxanthin with trypan blue for the even cataract surgery were introduced to the market, and another one with different lutein solution with brilliant blue and trypan blue is now available. So I only would like to remind you that maybe we can maybe minimize the phototoxicity, which is especially important by prolonged light exposure time and the prolonged macular surgery. It is only a hypothesis. We have not a hard proof that we protect, but according to the knowledge about the photoprotective power of naturally zeaxanthin and lutein, which is accumulated in human macula, yes, probably we should use it, especially in the terrific myopic cases. Thank you.
Thank you, Hannah. This is definitely no beginner's case. Congratulations for the difficult way of attacking high myopic eye. I think we can have, for this part of the presentation, questions to be answered by the panel. If anybody has any question about the dye, the chromovitrectomy, you're welcome to come to the...
I have a question and comment about Brilliant Blue. I'm using it for years, but when you use it in higher concentrations like ICG, when you're trying to peel the ILM, it cracks. It's more friable. If you use less concentrations in Brilliant Blue, it's less friable. So I think
can you define what's high or low concentration, like the 1% or the 1/4%?
I forgot the presentation she mentioned about that, but if you use higher concentrations, you could see it on her video also. If it's very dark blue, if you use higher concentrations, it's like the ICG. When you try to peel the ILM, it cracks. It's more friable. It's more difficult. So in medical, using less concentrations, if you have the same results using less concentrations, it's better. You can see the ILM better in higher concentrations, but I think it could be more toxic, like in ICG. So using less concentrations in Brilliant Blue, I think it's better. It's a little bit more difficult to see, but when you're peeling, you can have the hold and it's less friable. What is your thinking about? I don't think using higher concentrations is better. Less is better, and maybe it's less toxic.
Susanna, you want to have?
Yes, that's completely true about that it's cracks, but I'm, in a lot of cases, I don't know, the experienced people who peels a lot, there is difficult cases where you put and stain and wait, and sometimes you don't see it. So I think it's very important to have different choices for this type of cases, not to everyone. I agree with you, when you are used to peel ILMs, In a lot of cases, macular holes, it's very easy to peel the ILM, but there is difficult cases to peel ILM. When you peel a lot, you find cases where you don't see, even if you wait 5 minutes. So I don't know, the Jerzy, what do you think?
I think I didn't observe any changes according to the dilution of the dye, because I use always membrane blue dual and I do not change the dyes. However, I see a lot of changes depending on the status of the macula, what you said. In severe diabetics, old retinal detachments with PVR, ILM is different as compared to macular holes, and it is more difficult to peel in those cases. Also, high myopics are always a challenge.
Thank you.
Barbara?
Yes, in fact, I would like to highlight the PVR case. So the use of staining, not just to stain the ILM, but to stain the membranes. It can be very useful. I've been suggested to treat PVR after relieving the traction from the vitreous, to flatten the retina under air and then stain with the staining that stains both epiretinal membrane and ILM. However, I don't know what may happen as far as toxicity when the staining goes under the retina and they stay there. And no matter how you do this technique, a certain amount of staining is always going under the retina, of course, even if you do it under air, which is actually even more difficult because the retinal breaks may enlarge. Then when you wash the staining always goes underneath. So do you think it's more useful to treat better the epiretinal membrane to use the staining in that case, or the toxicity of it should prevent us to do it?
If I might take this, Barbara, the PVR cases, usually you release the anterior traction and you open the posterior traction as well, having a kind of easing off on the retina. So my feeling is like if you do a partial staining and on the less tense, less rigid taut retina, after removing whatever is seen there, the chances of getting the blue underneath goes little. And I think even if you get that, injecting PFC would just get the subretinal fluid out, including the blue as well. So
I think there are differences among staining substances. That's why I wanted to hear your opinion, because most of them who use the dual blue, in that case,
Jerzy,
it may not happen.
Yes.
I have tried I am now using the lutein blue staining, and I have observed a heavy subretinal staining, so probably to the thickness, the density is behaving differently.
Okay, Jerzy.
I think that we still do not have any evidence of toxic effect of blue staining. Actually, this is a theoretical discussion that in prolonged situation, membrane blue may be toxic. I never observed any sign of toxicity, and I always use in retinal detachment, and it always flows behind retina in those cases, because I just inject trypan blue. And I did it with membrane blue, and I do it with membrane blue dual, without air injection, without any improvements in staining, just as it is prepared by the company. And I never experienced any sign of toxicity. And recently, you see at veil vitrectomy and at Eckhart's meeting in Frankfurt, Rizzo presented 2 times a paper showing that there is really no sign of toxicity of majority of dyes if you use it for a short time. And always is question, what is more important? And I always think that more important is to perform your surgery well, to peel ILM, instead of thinking about toxicity, which is a hypothetical problem.
I agree, but I think we should, with every new staining substance, to do autofluorescence afterwards, besides, best corrected visual
Microperimetry as
acuity.
well. Thank you, Barbara. Dr. Sinclair?
When I try to peel idiopathic epiretinal membranes, I always try to peel the ILM underneath. In the United States, unfortunately, we have to use ICG, but even without ICG, in some cases of peeling idiopathic epiretinal membranes, I've been finding some post-operative visual field defects, periaxial. And I'm trying to figure out why. What's going on here? I think Jersey has also seen some using his Brilliant Blue. So I don't think it's the dye. I think it's the way we peel. And none of you have talked about this, but I think because of this visual field device that I have, I'm seeing them. Certainly the patients do complain about them, although they say the central vision and the distortions are better. But how do you peel? You say you go very slowly, but should we peel in particular fashions? I've been looking very carefully now at the OCTs preoperatively, and I think I'm beginning to predict where the epiretinal membranes are more adherent because there's some fragmentation. Certainly postoperative, the OCTs show defects in the nerve fiber layer and even ganglion cell layer. So I'm asking you, when you're doing your surgery and with the different stainings, how do you do it less traumatically? We have to do some, but how do we avoid these? Do you peel radially? Do you peel in a macular rexus fashion? But how do you try to avoid these kinds of, maybe I'm just the old surgeon who's experienced, but how do you peel?
Yeah, please.
Actually, it is a very important issue, what you said, but I do not think we can have answer how do we peel, because actually we peel with the aim to make some damage, as Didier already explained to us. But it is true what you said, but we observe in our cases and presented and published that in the paper about temporal inverted flap for macular holes, that defects in nerve fiber layer appear sometimes after several months after surgery, not immediately. We observed about 20% of defects just during first control after 1 week, but we had defects in 60–70% of cases after 1 year. So actually the issue is probably because of ILM peeling itself, and we have to understand what is better, to peel or not to peel. And probably peeling is better choice for the patient than not peeling.
Ahmed is having a quick comment, and then Didier.
Just a very quick comment to Stephen. Tom Williamson group from London showed that on a computer simulation model that peeling epiretinal membrane, if you peel tangential to the retina, that's much less traction and stress on the retina than when you're more anteroposterior. Sometimes it's a little bit more challenging when you peel tangential, but that's less traction. But that's on an epiretinal membrane model. I think on the same token, that might apply to ILM and also decrease the downfill, but I'm not sure.
So when you peel tangentially, you have to be careful not to bang the retina, because sometimes if you're focused too much on the membrane, you can just go and bang the retina as well. So Didier, quick comment.
Stephen is speaking about the pinching the retina.
Yeah.
Stephen, when you play with your kids, when you are playing with the small kids out to play at the Mikado, you know what a Mikado is? When you have to remove some parcel, some fibers like that, and you have to, without having the other to move. You didn't play that with your kids? It is not.
I went back and looked at the videos to define what I had done in those particular areas. Yeah. And it wasn't when I was picking up the membrane thinking, well, maybe I grabbed the nerve fiber layer and or ganglion cell layer, picked it too hard, but it was not. It was during the peeling. And I've tried to go more tangentially after that paper showed it. But should I go radially, so I'm peeling along the nerve fiber layer rather than peeling across it or across the often radial evolutions of the retina that are caused beneath this? I think these are things we should talk about.
But most of all, do what Weileweis showed this morning. It was perfect, that if you can maintain your hand you will be much more precise. You will be movement much more smooth. And this is why you should use or a slit or a chandelier, but don't work with the intraocular pipe.
Yes, what I'm trying to do is convince the surgical industries to give us a light that is parallel to the retinal surface so we can see those distortions as we're peeling as well. All these things I think will eventually help us.
Thank you, Stephen. Ivan, a very quick comment or question?
I'm not sure if we do have time for discussion now or later.
Can you do it later because we're just running?
Fine, I'm fine with that.
Okay, great. Thank you very much. So maybe we should think about standardizing our methods of initiating and peeling the ILM. That's a very good thought, Stephen. So moving on to the tamponade. How are we tamponading our holes? Using gas, using air, using silicone oil, and sometimes Dr. Koch will talk to us about the 3 cases of macular hole lately closed when the patient respected his positioning. So, Dr. Philippe Koch.
Yeah, thank you. I want to show you 3 cases of macular hole that lately closed when the patient respected his positioning. And indeed, macular hole is a considerable threatening for the central vision. And if reoperation can be successful, the risk of failure is higher when patients have already been operated once, and the resultant final visual acuity is frequently poorer. Positioning has always been a problem to obtain a good tamponade, particularly with elderly people and those who suffer from back problems. Face-down positioning for 4 or 7 days with gas is sometimes very difficult. In cases where the patient had too many problems of positioning and where the where the hole was giant, we can use some heavy silicone oil. Indeed, as published by Peter Stallmans, who is not a friend of mine, but he did a great job here. They performed a retrospective study with 54 eyes and showed that median postoperative, they obtained 100% of closure after 1 surgery, because you have to remove your silicone oil after that. But with 1 surgery, they obtained 100% of closure, and median gain of line was about 5 lines. In our group, we widely used Danciron 68 as a tamponade for almost a decade, and we asked patients to lay on their back at night for the first week. We confirmed the Peter Stallman's study in cases with positioning problem and in cases with large macular hole with a poor prognosis like Alport syndrome, trauma cases, etc., etc. We do not observe any more inflammatory reaction because in 2007, 2008, we had few uncommon cases with quite a lot of inflammatory reaction, but not anymore. And with macular, we obtained the macular hole closure within normally 24 hours postoperatively, because as you know, with Danciron or silicone, you can perform OCT. And amongst the macular holes that closed, let's say that every macular hole closed at 72 hours for the last one. But of course, you're right. We have 99% of closure with gas, and final visual acuity is very comparable between Danciron and gas, and it requires 2 surgeries. So we of course restrict our use of Danciron 68 to very severe cases. And I would like now to report 3 cases of macular hole closure that did not close in early follow-up, but a few weeks after when I asked the patient to position appropriately. I will particularly show you one case that is a recent case because the other one I had poor OCT. It was a 64-year-old woman who was sent to me with a stage 3 macular hole, and because the hole was probably quite long, I decided to operate her very rapidly in the afternoon. And we used some dance serum because she was not able to do it by other ways. She had very strong back problems. At first visit, day 1, we don't have inflammatory reaction, no hypertension, and the vitreous cavity was filled by, with 95%. But at the second visit, 3 weeks after, as you can see, definitely the hole is still opened, and you have the reflectance of this dance serum. I just asked the patient to understand how she was sleeping at night, and she told me that she was moving a lot because it was almost impossible to remain on her back. So I asked her to use pillow to block her body when sleeping. And as you will see on the lower OCT, 1 week after, still under dance serum, the hole is closed. Okay. So I removed this dance serum 2 months after initial surgery, and finally visual acuity went up to 0.5, and I'm still following her because it's quite a recent case.
Just a question, Dr. You mentioned also that there's been like few days to have to notice the hole closure, even if it's a bit delayed. So would this be appropriate to plan to remove the densirone like immediately after noticing the hole closure? Are you comfortable doing that, or because we all know about the complications of densirone in the eye if it stays more than it should be?
Okay. First of all, I tried to remove the densirone at 3 weeks, but I think that because of infusion line, probably the hole is sometime reopening, okay? It happened, 1 or 2 cases. So I decided to leave the densirone for approximately 6 weeks to 8 weeks. And I don't have any problem, particularly no glaucoma problem, because I'm frequently washing my, I'm always washing my anterior chamber during my surgery when I remove the silicone oil, To remove the silicone oil, what I do is to make fluid air exchange 3, 4, 5 times until I'm sure it's cleaned. And then I put the cavity under air and I wash the entire chamber. So the bubbles of densirone are falling down to the posterior chamber. And then I wash again the posterior chamber and I move the way.
Would there be an ideal time between observation of hole closure and then decision to remove the densirone not to get a recurrence? If you see like in 5 days' time it's closed, would you leave it for 6 weeks, or you think of removing it early, especially if you have complications?
Of course, but as I told you, I don't see so much I don't have complications on this point.
Excellent.
And the other problem could be inflammatory reaction, in the anterior chamber, if we operate too quickly, perhaps. So if we jump to conclusion and perspective, what is interesting in this presentation? I have, first of all, 2 other similar cases observed in the last 10 years with back problems each time. My first question should be, is a conventional tamponade sufficient to close the hole? We see in the literature actually many articles saying that you don't have to be positioned, etc., etc. I'm not always sure about that, because here it is cases where the positioning was a problem, okay? So I think that in some cases we need to be to better understand which kind of macular hole we have in front of us to try to identify the one which will fail probably. So was it due to a perioperative problem? Definitely not, because for legal reasons, just for safety, I'm recording every surgery, and I keep it on a hard disk, hard driver, and I looked again on this video, and it was a normal conventional surgery without problem. Was it insufficiently filled with silicone oil? No. I had 95% of densirone in my vitreous cavity. Was it excessive eye movement? No, because the patient is not moving her head because she has a problem on her back everywhere. So my take-home message will be that when we fail in first intention with gas, perhaps we should consider to do it again, just injecting some gas. Indeed, it could perhaps be interesting to see how the patient is positioning and to ensure he is doing it well and just inject gas again, because we are frequently at 2-3 weeks after the initial surgery, and I'm sure the scarring process is always running. So I think it should be interesting to try to re-inject again and not to try to touch the retina, touch the macula or everything else. Thank you very much for your attention.
Thank you very much, Philippe. Very nice thoughts. So now we're going to the chemical vitrectomy by the use of ochriplasmin. Definitely we will not be stop doing vitrectomies, but the ochriplasmin is there, and Dr. Fernando Faust will present his experience with the intravitreal ochriplasmin in vitro macular retraction with or without macular hole.
I'm going to present our experience in use of intravitreal ochriplasmin in our hospital. And the purpose of this work is to evaluate the results after the ochriplasmin use release of vitreomacular traction with or without macular hole, and the evaluation was the success of treatment in release of vitreomacular traction and the close of macular hole in our patients. We injected 15 patients. The mean of the age was 70 years old. Mostly they are women and phakic. And the follow-up was the baseline, the 1 week after injection, and 1, 3, and 6 months after injection. And we control the best correct visual acuity, intraocular pressure, and spectral domain OCT was made in all patients, measuring the central retinal thickness and the station and the area of vitreomacular traction and the macular holes using phase protocol. And of course, we take all the adverse events in our patients.
So can you explain why is it your favorite method as regard to other surgical modalities?
Well, indeed, ochriplasmin is not my favorite method, but we use this treatment because I'm going to explain later. Ochriplasmin is, I believe that is only for some cases. So I believe that we have to choose very, very carefully this kind of patients that we have to use. So our results is the rate of release was 64.5% of our patients. The mean of station of the traction was 497 microns. And the mean of central retinal thickness was 335. And we measure also the area, because we think that maybe we can observe some differences between the extension of the traction and the area, because it's not the length, only the length, also the area that we can observe in this traction, because this use unphased protocol. And the macular hole associated, we have only 4 patients, but the close of these patients was 75%, yes. The visual acuity improved from the baseline about 2 lanes, from 68 liters to 79 liters. And the effect adverse was not really serious in local neither systemic effect. We have photopsias, moreover, the first week of after injection, and the patient has a lot of floaters, and some of them have a transient lost vision, but all of alteration in the color vision, and also transient subretinal fluid. But all of these disappear during the follow-up. And in 2 patients, we have some loss of outer segment ellipsoids, but after 6 months of follow-up, in these 2 patients, this complication disappeared also. So for us, the ideal case is ventromacular traction without epiretinal membrane, and the station must be less than 1,500 microns. And when it's really associated to macular hole, the macular hole must be less than 400 microns.
So just here, you didn't comment on the lens status, whether phakic or pseudophakic. And I think this is the important parameter also in success. And would you consider that the 75% macular hole closure rate satisfactory to you?
Well, I'm not sure though. I don't know exactly if the status is phakic. It could be better in our patient. It was in this way, but I'm not sure the status of
Thank you.
So, in conclusion, ocrelizumab, it could be a possibility of treatment in some patients with retromacular traction and macular hole. We can't not found a clear relation between the extension, the length of the traction and the area. In our cases, we can't found that there are no relation between them. I believe that we need more studies to understand exactly what is the mechanism why this medication can work or not, because sometimes we have observed also in our patients that there are some of them that they have not very length traction, but in this case it doesn't work, and in other cases that they have more length, it works perfectly. I believe that the rate of release is not high to consider in all cases of retromacular traction, and of course before to put this treatment, I believe that we have to be very careful when we choose the patient. We have to put this kind of treatments. That's all.
Thank you very much, Fernando. So now we're moving to the ILM peeling, which is, I think we have so many experts on the podium using the microforceps, the conventional way we all used to. Some surgeons, however, advocate the Tano scraper. Some others believe that this is harmful. Maybe the presentation by Dr. Paolo Tassinari will give some answer to the better method of peeling the ILM.